Hello, my name is Jan Leif.
And I am Muskan Joshi.
Welcome. Welcome to MedNews Week conference where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Pashtoon Kasi. Dr. Kasi is the Director of Precision Medicine Research for Liquid Biopsies at the Engler Institute for Precision Medicine, the Director of Colon Cancer Research at Weill Cornell Medicine at New York Presbyterian Hospital in New York.
In today's presentation, Dr. Kasi discusses about the assessment of circulating tumor DNA and the circulating tumor cells in patients with cancer.
Did you know that Dr. Kasi is a best-selling author of What, Why, and How, a treatise from researchers to researchers, and a global leader in the field of liquid biopsies and ctDNA-driven clinical trials?
A true global leader in the field of oncology.
So let's tune in and learn from this global leader.
Our disclosures are listed. We will be talking about off-label use of some of these liquid biopsies. I've also been on consultancy and advisory board meetings with several of these companies, given our expertise. These are also available at our website at Cornell, as well as at ASCO. So what are we going to talk about? We're going to talk about this exciting new area of research as well as clinical care that is relevant to pretty much patients with all types of cancers called liquid biopsies. The term liquid biopsy is a misnomer since no actual biopsy is being performed. This is more of a phlebotomy or blood draw. What it entails is similar to how a lot of this actually technology, it's interesting to note, was started in pregnancy and prenatal diagnostic testing. Just like a fetus growing in a mom's womb, it shed its DNA that can now be detected in the blood as early as first trimester of pregnancy, almost 8 to 10 weeks of gestation, to know the sex of the unborn child, as well as if there are any genetic abnormalities, just by a simple blood draw. The same technology has been extrapolated to transplant, because if you think about somebody getting a liver, kidney, or heart transplant, the donor organ is also shedding its DNA in the circulation that can be again captured by a non-invasive blood draw. The tumor as well, in this case solid tumors, when we refer to cancer, they can also shed its contents, which includes DNA, cells, that again can be captured by a non-invasive blood draw. So it's kind of like a biopsy of the cancer by a simple blood draw. That's why the term liquid biopsy. So when people talk about liquid biopsy, it's not just limited to circulating tumor DNA and circulating tumor cells, but also there are a bunch of other tumor fragments, as one of my other oncology colleagues puts it, a lot of tumor trash that you can capture now in blood, which includes exosomes, glycoproteins, RNA, and the list keeps going on. In the clinic, when we talk about liquid biopsies, primarily we're talking about ctDNA, and then I'll also show you how CTCs are making their way in the clinic. Again, liquid biopsies are something that are having an impact at all phases of a journey of a patient with cancer, from diagnosis to this new area of research and clinical care called minimal residual disease, and we'll tell you what that means, and also assessing treatment response as well as acquired resistance. Some of these articles are open access and available online for those who would like to read more about this topic. Again, where is this ctDNA or tumor trash in the blood coming from? So cancer cells are actively dividing. They can make their way into the circulation. So you can see CTCs or ctDNA in the blood by actual transfer and migration. But also you can see some of that through just regular turnover or death or apoptosis, necrosis. And as your body's trying to get rid of it, you can notice some of that traffic into the bloodstream. Again, this has a very short half-life, which makes it poised to rapid assessment as well as changes in cancer treatment over time. A little bit of nomenclature and some of the terms that you will see, since a lot of the terms, like I mentioned, originated in the world of pregnancy and fetal testing and prenatal diagnostics and transplant. The terms often refer to circulating cell-free DNA or cfDNA. And as the terms were included to use for cancer, then came along the terminology ctDNA or circulating tumor DNA. The liquid biopsies don't just tell us about mutations, it also tells us about other abnormalities, aberrations, so to speak, also something called microsatellite instability, which is now very relevant since this is something for whom the immunotherapy is now approved agnostically. This also has relevance for individuals who may have something called Lynch syndrome. Again, going a little bit deeper, it's important to realize that it's not just one shop test, one option. There are many kinds of liquid biopsies. One way of looking at the liquid biopsies is how they are doing the test. So there are what we call tumor-informed platforms versus tumor-agnostic or tumor-uninformed or plasma-only platforms. This is how all the liquid biopsies actually started, where it was meant for as a replacement to tissue biopsy and incorporated something called next-generation sequencing or broad genetic panels, and primarily the use is in advanced or metastatic solid tumors. So as you can see, it's important to realize that there are different kinds of liquid biopsies depending on the question you're asking. Recently, something called tumor-informed platforms have come into play. Again, in this case, as the name suggests, you need to send a piece of tissue, they sequence it to make a barcode simplistically, and then they look for the same barcode in blood. So its use is primarily to monitor cancer, and is mainly relevant for that particular patient, that particular tumor at that instant in time. It's not relevant or fixed to one particular type of cancer, but could be used for potentially any kind of cancer as long as you can get tissue. That also adds to the pros and cons. You need tissue to be sent. This can be more time consuming of an exercise. Whereas the plasma-only platform, the rapid turnaround makes it very attractive, with some of the turnaround now being in the order of 7 to 9 days. This is another cartoon reflecting the same. Again, in the top panel, you see what we call the tumor-informed platforms, where essentially you need to send a piece of the tissue that's sequenced to look at the barcode, and then look for the same barcode in blood. So it's, whatever signal you detect, there's a very high chance that it's going to be a positive signal, as opposed to the tumor uninformed or plasma-only platforms. There are two kinds. One that were the traditional liquid biopsies that are only looking at DNA and are meant for next-generation sequencing-based panels, and for essentially stage 3 or stage 4 cancers, advanced or metastatic, so to speak. Whereas some of these new tests, which have this novel epigenomic testing added to the DNA testing, the epigenomics markers are also called methylation markers. They are making its way into early detection, but also increases the sensitivity of these assays if you were just focusing on the DNA part. These are now specifically coming out for specific kind of cancers. In GI cancers, for example, we have now in clinic both tumor-informed platforms, but also plasma-only platforms as well. So again, to reiterate, ctDNA or circulating tumor DNA is something that is having an impact at all phases of a journey of a patient with cancer. And depending on the question you're asking, there are different kinds of liquid biopsies available. I've seen this common error being made where somebody's trying to answer the question of minimal residual disease or thinking of using it for diagnosis, but then they're ordering the test that's actually meant for latter stage of cancer. So it's important to realize to know what test is being ordered for what clinical question. Some of the landmark articles I wanted to highlight for the audience to share. Again, these are available online. Some of them are open access. This was one of the first consensus statements from the American Society of Clinical Oncology, the ASCO, and the College of American Pathologists for joint review, looking at all the different challenges and things that we will talk about liquid biopsies in a very nice, succinct format. And it's still relevant today. This was published in March 2018, and a lot of the times the consensus there was a lot of these things were not ready for prime time. But 2018 seems like yesterday, but it was 4 years ago, and things have exponentially gone up, whether it comes to research in liquid biopsies. If you were to just simplistically just type in the term ctDNA or liquid biopsies at any of the major conference, there are hundreds of abstracts looking at various kinds of liquid biopsies when it comes to specific cancers, for looking at detection, for looking at stage 4 disease, for looking at even DNA. When we talk about circulating tumor DNA, it's not just circulating tumor DNA in blood, but we are seeing research in the fluid in the belly called ascites, in the lungs, mucus, urine, so CSF. So again, you can detect any of these technologies now, while there may be blood specific, but in the realm of research, other types of fluids are also being analyzed. And again, these are not my slides. These are slides from discussants across the country. I'm not the only person who is saying that some of these technologies, with its limitations, are ready for prime time. And even within a few years, as you can see here in what the discussants are outlining, some of the recent task force statements as well, these are things that people are already saying that it is actionable, ready for prime time. And especially in the world of trials, a lot of this is already available. Again, depends on what phase of a journey of a patient with cancer we're talking about. You may have a lot of cancer when somebody is diagnosed with it or when they have metastatic disease. But this new area of research called minimal residual disease, which is after curative intent surgery, has become a hot topic of debate in terms of how can you assess who are the ones who need, like, for example, in GI cancers, mop-up chemotherapy, and who are the ones who could be spared the trouble of not going through the toxicity of chemotherapy. Now, how is this relevant to us, especially for us focusing on GI cancers? This is good timing. March is Colorectal Cancer Awareness Month. And what is concerning, as some of you might already know, more and more young people are dying of colon and rectal cancer. We don't know the reasons why individuals who are in their 20s, 30s, and 40s are getting diagnosed with rectal cancer and colon cancer. And it's not just genetic, whether it's the diet, whether it's the so-called microbiome. The millennials particularly are up to 4 times at high risk for rectal cancer for reasons that are still being analyzed. This is some of our research published several years ago. This, alongside many other findings, have led to the age of screening being moved to 45 years of age and has recently been endorsed by multiple guideline committees. So anybody above the age of 45 for average risk needs to be screened for colorectal cancer. Again, this cannot be overemphasized. March is Colorectal Cancer Awareness Month. And this is one of the few cancers, one of 5 cancers specifically, where there is at least screening tests available, as in different kinds of tests. And we'll also be talking about some of the future of some of the non-invasive blood tests available for detection now as well, very soon around the horizon. Now, in the context of colorectal cancer, we think of colorectal cancer as a long piece of plumbing, a long piece of tube, but even within this, it's not the same type of cancer. Even the side of the cancer makes a difference, as in the patient's left side of the cancer arises from that part of the body. It has very different molecular profiling and different prognosis versus cancers arising from the right-hand side. And some of this has to do with the embryological origins of some of these cancers, where the right-sided cancers are derived from the midgut, more common in females, and the left-sided cancers are derived from the hindgut, more common in males. And as you can see here in this cartoon, they are completely different beasts altogether. This is even getting more complicated in a good way, where we have now many options for patients with colorectal cancer. Shaded here in blue are some of the traditional chemotherapies, the genetic biologics, some of the targeted therapies, some of the pills that are used in the refractory setting, some of the more new precision medicine-based therapies for select subsets. As one of my colleagues put it, it's kind of identifying subsets of subsets, that the advances for patients with a lot of different cancers are coming in subsets, while we may not have come up with drugs to solve all cancer problems. For these select subsets, like, for example, HER2 colorectal cancer, or the MSI high that are candidates for immunotherapy, or those who can get the new kind of pills called NTRK fusion inhibitors or BRAF inhibitors, for these, the advances have been more so than others. Now, why this is irrelevant in the context of liquid biopsies is, as you can imagine, after having gone through so many different kinds of treatments, chemotherapy, any average colorectal cancer patient goes through at least 4 or 5, if not more, lines of therapy, depending on the clinical trials and stuff. What that means is, by the time somebody may be seeing us in clinic 3 to 4 or 5 years later, I saw several patients last week for second opinions who had gone through at least 4, 5, 6 lines of treatment. It would be hard to imagine that the tumor is the same. It's shown here in this cartoon. A lot of the times the problem is, it's not that our treatments don't work, it's just that at some point in time they stop working. Shown here in the light blue are probably clones that we are able to wipe out, and then the resistant clones that might have been there to begin with, or sometimes it's truly acquired clones. Shown here is like the Darwin's theory of evolution, the survival of the fittest, where the resistant clones are able to survive and then later outgrow what is present in the cancer. So the cancer is not just black and white, but it's probably these shades of different colors. And this is more so relevant for patients exposed to target therapies. As I was alluding earlier to Dr. Chandler Park's comment, I've been more of an early adopter that stumbled upon liquid biopsies. A lot of this is, and I owe it to my patients, a lot of this is something that I learned in the clinic, took it back to the lab, learned more about it in trials, brought it back to the clinic. This is one of the first patients that I had where, again, the question for liquid biopsy came from the patient. Again, as illustrated earlier as well, this is one particular patient who had colorectal cancer, young guy in his 30s, who had gone through, as you can see, 5 different kinds of treatments, chemotherapies, something called a liver pump, where they infuse chemotherapy, high doses into the liver. And then after going through all these options, the cancer was still growing again. Shown here in the white are actually the dead cancer part, but then the dark shadows are the ones where there is new cancer. And again, going back to how I had illustrated that, these cancers are not the same, I would like to get a biopsy to see what has changed here. But the patient, had, after having gone through so many surgeries, procedures, biopsies, pumps, was just done with further procedures, but was open to anything else that I would do or suggest, but no more procedures. So I had heard about, something called a liquid biopsy or a blood test that can potentially inform me of the genetic makeup or changes over time. So I ordered it and I stumbled upon a pretty interesting set of results. Shown here in these colors or curves are different mutations and aberrations that were not present in the patient's tumor before, but were now present as new mechanisms of resistance. The patient's tumor, simplistically speaking, was just the blue shade of the color, none of these other fancy colors that were later acquired as an outcome of being exposed to some of these targeted therapies. So we were able to do some radiation and then got some disease control. Later on, the patient developed lung metastases, but when we repeated the liquid biopsy, as you can see, the fancy colors or the mutations or mechanisms of resistance had faded away. So we were able to re-challenge the patient with the same drug that had stopped working without any chemo. And again, it started working again. Now, this wasn't a cure by any means, but we were able to do re-challenge or recycling of therapies, which we often do it in a blindsided way, in a more informed fashion using ctDNA. We've presented and published on this topic years ago, and some more recent work from MD Anderson has looked at even the half-life of some of these resistant clones, where anywhere from 3.5 to 7 months, some of these resistance mechanisms fade away. And that's where arbitrarily in the world of cancer care, if you ask oncologists, we always are more enthused about re-challenging something that hasn't been used in 6 months or so or longer, but sometimes they work, sometimes they don't. Why is it the case? What's actually happening is, as illustrated here in this cartoon, you have these sensitive clones that we are able to take away, whether a resistant clone, survival of the fittest, outgrows, or truly this is an acquired mechanism of resistance. But cancers at the same time are very efficient machineries. If you kind of throw off the cancer and start using something else that is not messing up with the same highway, things kind of, simplistically speaking, the dust settles down. So the cancer is able to go back to what it was. And here you have an opportunity to maybe re-challenge or recycle the same drugs that stopped working. This concept has been shown in this so-called cricket trial, the cave trial, and the recent Chronos study, where, as shown here in this cartoon, what they were able to do was, as long as you didn't have these resistance clones or mutations shown by this multi-cancer giant cancer mass, where there are multiple kinds of resistant cancer cells, if you gave this kind of patient the same recycling therapy, it was not going to work. But if you waited for these clones to fade away and then give these patients the same target therapy that they were exposed to before, it again wasn't a home run, but added clearly benefit to patients who didn't have these aberrations. So while the advantage may be modest, but you can spare the toxicity to those who probably are not going to benefit from this approach. The other basic question of liquid biopsy, can it be used in place of tissue biopsy? This is a patient of mine. Again, a lot of what I've learned over the years have been in individual patient stories, then later leading to bigger studies and analyses. In this particular patient's case, as you can see clearly at 3 different time points, we can easily see that the patient's tumor is a BRAF V600E mutant, one of the most aggressive kinds of colon cancer. We can clearly see other partner mutations like APC and stuff. But at all these 3 time points, interestingly, we could never complete a tissue biopsy because the tumor was so what we call mucinous or mucus fill, that the actual amount of cancer tissue needed to do tissue biopsy testing was never sufficient. But since we knew that this patient had it, we kept pursuing biopsies where it was safe. And this was one of the first patients that were actually enrolled in the so-called Beacon trial that was published in the New England Journal, where now the BRAF inhibitors alongside EGFR inhibitors is an option. Had we not known about this through the liquid biopsy, this is somebody who probably would have never had the opportunity of going beyond that particular trial. Now, this is something that's available in the NCCN guidelines, also approved by the FDA as an option. Again, looking at the mutational makeup of colorectal cancer, again, this is relevant to other cancers too. Mutations are easily some things that are detectable in liquid biopsy, as shown here in these different curves. What are you seeing in red are the frequencies shown in liquid biopsies in over 1,000 patients with colorectal cancer. And this correlates with previous large studies where we've done tissue testing. How about predicting mutational burden? As you know, or might have heard, the more hyper mutated your tumor is, as shown here by some of these fancy colors, the better chance of immunotherapy working. This is something that can be now officially calculated by something called the blood TMB or the liquid TMB or the blood tumor mutational burden. While this is something that is a resistance mechanism to some of the chemotherapy drugs, counterintuitively, immunotherapy works better in these kind of scenarios. Looking at some of these other markers that are relevant to other cancers besides colorectal cancer, one thing that's very pertinent to all cancers is something called mismatch repair deficiency or microsatellite instability. This is something that's done on tissue routinely, and now we have agnostic approval. This is the first time the FDA approved a drug regardless of the tumor type. So somebody could have colon cancer or bile cancer or breast cancer or lung cancer. As long as you can detect MSI high or show that the tumor is mismatch repair deficient, they can be candidates for immunotherapy called pembrolizumab. Since then, we've now a total of 4 approvals. Pembrolizumab immunotherapy also got approved for tissue TMB cutoffs of more than 10, and we have now 2 FDA-approved recommended pills for NTRK fusion harboring cancers, which also tend to be high in the mismatch repair deficient MSI high tumors. What that means here is, again, goes back to the concept of subsets of subsets. While we may not have achieved home runs for individual or all cancer types, for these subsets that may harbor some of these aberrations, you need to be able to identify them, because it's simplistically more like lock and key. If you don't identify the lock, you can't prescribe the key for it. The plasma microsatellite instability can now also be detected in the blood. We were part of the validation study, and interestingly, what we also found were a lot of these instances where we would have never known about the MSI because the tissue was never sufficient. So some of these patients that are picked up on the liquid biopsy would have had never the chance of getting immunotherapy, which is the only time I've seen the experts to use the word cure. So this is not a small finding, and gone are the days when we used to say, well, 2% or 4% is rare. Nowadays, it's all about finding every single patient who may be candidate for something that can have a bigger advantage and is precision medicine based. If there's one talked about target for which there have been more drugs and activity, it's HER2. People might have heard about this in the context of breast cancer. This is present in a third of gastric cancers, esophageal cancers, also a subset of colorectal cancers here are known to be HER2 positive. And for these patients, there are now 3 cocktails of HER2-directed therapies as part of NCCN guidelines. And can we detect this in blood? As you can see in this one study, in the 48 samples, they were able to identify the HER2 or the ERBB2 amplification in almost every single sample. So the numbers kind of speak for itself. So you can use liquid biopsy and the signal if you get in a HER2 positive patient. If they have a HER2 positive signal, you can act upon it. What about fusions? These are large gene rearrangements. Liquid biopsies in general are considered, one limitation is that you can't pick up fusions. That statement is not entirely true. What that basically means is if you do pick up a fusion on a liquid biopsy, it's real. It's just that you can't use liquid biopsy as a means to say for sure that, oh, I did a liquid biopsy, there was no fusion, so it basically means there is no fusion detected. Tissue would always be the gold standard when it comes to fusions, However, liquid can increase the number of people where these fusions can be detected. Specifically, often fusions are acquired mechanisms of resistance seen post-EGFR blockade. So unless you do repeat tissue biopsies, which sometimes it's not safe, feasible, or practical to, we keep doing biopsies again and again, liquid biopsies can fill that void. Switching gears to a different kind of cancer called cholangiocarcinoma, which is what we call a target-rich disease. This is cancer arising in the so-called plumbing of the liver, leading into the gallbladder and the bile ducts. And even though, again, it simplistically looks like, all the same color, they have different mutational molecular profiles altogether. We had published this several years ago using liquid biopsies to show different actionable aberrations. Now, again, we're not talking about random mutations for which they may or may not be drugs. For a lot of the things shown in green here, we have FDA or NCCN guidelines endorse approved drugs, and shown here in blue are drugs for which we now either, again, can go through the guidelines or sometimes find the right clinical trial for some of these patients, or even pursue off-label therapy with some optimism, because we know there is increasing pool of data that these treatments can work for these subset of patients. And again, we're building upon the story of completing the genotyping. This is an underestimated issue that often tissue testing fails. As shown here, this is a study that the paper should be coming out soon. We also presented this back at ASCO. Interestingly, we stumbled upon more fusions in the liquid biopsy as opposed to tissue biopsy from a testing platform that had both tissue and liquid. It's not that, again, tissue is the gold standard when it comes to liquid. It's not that the liquid was better than tissue, but because liquid was more often completed, because tissue often had the fallacy of not having enough cancer in the specimen, and biliary tract cancer or bile duct cancers, often there's not enough specimen to do mutational testing. Overall, the number of fusions and other actionable aberrations picked up on liquid biopsy, because this was more often completed, was actually higher. Even conservatively speaking, we found actionable aberrations at least a third. Some of the series estimate up to 30 to 45% of the time. If you kind of spin the wheel, you'll find land on something actionable. This is, again, a bar curve illustrating the same. And again, for the select patients where you do identify actionable aberrations like HER2, present in about 15 to 20% of extrahepatic cholangio. And I was just talking to some of my colleagues earlier today about 2 different cases of metastatic gallbladder cancer. Gallbladder cancer in some series is reported to have HER2 at the same rate as breast cancer. Many people don't know about it. Again, you'll only pick up this if you test everybody. Nobody has this written on their t-shirt that they have whatever aberration they walk in with. So you have to test everybody. In the context of FGFR fusion drugs, we know, just like other targeted therapies, these drugs work, but then they stop working at some point in time. Liquid biopsy can pick up some of these resistance mutations up to months before the actual progression on scans. What do we do with this is going to be interesting now that we have several kinds of both what we call reversible and irreversible inhibitors of the FGFR pathway, including novel drugs that can even overcome some of the resistance mutations seen by these first generation of drugs. The other big area of a lot of activity, at least in the last year or so, is something called ctDNA kinetics, meaning doing serial testing, meaning more than one testing. Can we use the changes in ctDNA to tell us if somebody is responding or if somebody is having progression, meaning their cancer is worse on treatment? Why is this relevant, and why ctDNA can do that? ctDNA has a very short half-life, a few hours to no more than a few days, as opposed to some of these protein biomarkers like you might have heard of CEA, CA19-9, CA125. A lot of these are what we call glycoproteins. They're not entirely specific to one kind of cancer. In fact, they're not even specific to cancer. You can see elevations of CEA in smokers. You can see elevations in hypothyroidism. There's probably a dozen other causes that are non-cancerous that cause some of these markers to go up, as opposed to ctDNA being a very specific marker. But more intriguingly, because of the short half-life, if you start them on something that works, for example, in this particular study, if you were able to start them on a treatment that works, ctDNA can fall and become undetectable within weeks of administration of an effective therapy, or for that matter, surgery. This is a patient of mine who had 1 dose of immunotherapy for NMSI high gastric cancer. And again, we underestimate how quickly immunotherapy works, and we wait for scans in 2 to 3 months. And we also talk about this progression or pseudo progression. ctDNA, because it goes down so quickly, we've seen, and Again, other colleagues have reported the same, and there are other bigger studies reporting the same observations as well, that ctDNA kinetics, even as early as 2 to 3 weeks of administration of immunotherapy or target therapy, can predict responses months down the line. This is another example of a patient, in this case, not responding to immunotherapy, MSI high cancer with an NTRK fusion, where, as you can see, the ctDNA, the colors were not even budging, or in fact, for that matter, were actually getting worse. But then as soon as we started the patient on something called larotrectinib, which is an NTRK fusion inhibitor, within weeks of administration, the cancer DNA, circulating tumor DNA, ctDNA became not detectable. This patient went on to get a surgery where all the stage 4 cancer, by the time the surgeon took it out, was already all dead. So again, it may seem like small numbers, but for these subsets, these are loose balls that you got to hit a home run on. Again, simplistically speaking, these are easily definable entities on serial blood draws. And you can also use something called MSI status, disappearance of which correlates with DNA, as we've shown earlier. Again, this is not just relevant to GI cancer or colorectal cancer, it's relevant to all kinds of cancer. This paper, published in August 2020 in Cancer Discovery, looked at changes in ctDNA, either clearance or fall, or for that matter, rise, which was pretty ominous, and these patients did horribly, both from what we call progression-free survival as well as overall survival. So putting patients' responses into these 3 buckets can help you prognosticate and predict responses months ahead of the actual scan results. This is another study published in Nature Cancer using a different kind of assay, different liquid biopsy. Again, I often get asked this question about, what about this assay, what about that assay? It's less about the assay, it's more about the science. Regardless of the assay, clearance of ctDNA is always the best thing you can hope for. And these patients are alive years out. These are patients with metastatic stage 4, different kinds of cancers. Whereas a fall is helpful, they do better somewhat, but a rise of ctDNA or no change is ominous. And again, this equates to changes that we see in progression-free survival as well as overall survival. This is an editorial that we published a year ago, looking at some of these studies that are looking at the kinetics of liquid biopsies, which is again relevant to different kinds of cancers. This is another example of a study from one of our colleagues, Dr. Parikh, at MGH, looking at, again, it's not just about immunotherapy. While it's fancy and neat to talk about immunotherapy responses, ctDNA changes can also predict chemotherapy responses. Sometimes it's not as cool to talk about chemotherapy responses. So you see a lot of these studies about novel targeted therapies and ctDNA and novel immunotherapy and ctDNA changes. But on an effective chemotherapy regimen as well, you can see changes in ctDNA that can correlate with response, 8 to 12 weeks down the line. Again, these are ctDNA changes in terms of percentage, simplistically speaking, of patients who had a partial response, who had stable disease, or who had progression disease, meaning that their cancer grew on treatment. This is also being used in a lot of studies for early readout. So clearance of ctDNA is the best thing you can hope for. This can allow for novel designs of trials and also getting a quicker readout, as opposed to waiting for months, or in the context of adjuvant studies, waiting for years for the cancer to recur. You can use some of the molecular relapses or changes early on to potentially halt the trial if things are not working, and maybe identify the patients who are deriving more benefit kind of in some of these pick the winner design clinical trials. Moving on to the other topic, that's a very important area of research now, that, a few years ago when I was approached about some of these trials and research that were coming in the space, I honestly didn't think that this was possible, because again, I was looking at the lens of the lens of liquid biopsies that are next generation sequencing based platforms that are looking at cancer, that I didn't foresee that you could use it for stage 2 or 3 cancers after they have surgery, after they have nothing available on scans. So what are we talking about? We're talking about minimal residual disease, or MRD. We're talking about cancer that's not detectable on the scans, but maybe present in the body. So shown here in this cartoon, in this green, is our patient who's not cured, who probably would benefit from mop-up chemo and maybe more intensification of therapy, as opposed to somebody who's shown here in the dotted line who's already cured. Right now, we cure a lot of patients with surgery alone, but we don't have a way of telling patients apart as to who's cured and who's not cured. So right now we give therapy to everybody, for example, with stage 3 colon cancer, but do everybody need chemotherapy, and can somebody be spared the toxicity? This is what the hope and goal of liquid biopsies is. But remember, the detection limit of these assays is not 100%, as we'll show you in some of these slides. But why some of these cancers are more suited, it's not again just about the assay, it's also about the disease. Some cancers, like for example, colorectal cancer, small cell lung cancer, are high shedders of DNA, so you can detect more ctDNA head to head as compared to some of the other cancers. Now, not surprisingly, for example, gliomas or brain cancers have very less circulating tumor DNA detectable in blood. I'm actually just surprised about the fact that you can even detect ctDNA in a patient with brain tumor. The fact that it's lower is not surprising, but again, it all boils down to the clinical context, the tumor type, not just the assay at large. So what I'll show you next is a series of curves. Honestly, if I didn't label them, you won't be able to tell which assay, which company, which tumor type. They all have very similar striking results. So shown here in this orange or line, or the curve here, are patients who are noted to be ctDNA positive after their surgery. And as you can see, within a couple of years, every single patient had a recurrence, unfortunately, as opposed to the ones who were ctDNA negative. It's not 100%, but there are a lot of them, up to 90% of the time, were cancer-free years out on longitudinal testing, meaning that they're testing at more than one time point. For the ones where they were able to look at serial testing, if you had ctDNA and we used mop-up chemo and you cleared ctDNA, you were still cancer-free years out. But if you didn't clear it, or if it was transient, every single one of these patients had recurrence. This is not something that's new and unique and to one assay. Another study, similar results. ctDNA positive, every single time the curve meets the x-axis, you have recurrence. ctDNA negative, not 100%, but still pretty separated out from the ctDNA positive. This is a study published almost 14 years ago. If you were ctDNA negative, almost a straight curve, as opposed to ctDNA positive, recurrence within a couple of years. Different study, different assay, same results. ctDNA positive, every single time it's ominous. ctDNA negative is not 100%, but pretty darn good. Again, different assay, different settings, same results. If I were to put all of these assays, these are better than the usual genetic CEA tumor markers. And if you see a consistent theme that if you're ctDNA positive, it's ominous. If you don't do something about it, they all recur, as opposed to ctDNA negative not being 100%. But then the bigger question is, is it that this all stage 4 cancer that we're detecting and that we can't do anything about since everybody's recurring? That's not entirely true. Again, all the data that I showed you here is when you did nothing. These were biobanks of patients and providers that didn't know what was going on. So these were research conducted retrospectively. This is research looking at 3 and 6 months of chemotherapy. Again, this was prospectively collected data, but again, the ctDNA testing was done retrospectively. Not surprisingly, if you were ctDNA negative, didn't matter if you got 3 months of chemo, 6 months of chemo, you did fairly similarly. But if you were ctDNA positive, that was a bad sign. Then you benefited more from 6 months of treatment. Recently at ASCO GI, we're kind of used to seeing these differences between ctDNA negative and ctDNA positive. We saw for the first time hints that this may not just be a prognostic marker, meaning it doesn't just tell us about all good or all bad. It also tells us about is the benefit and who may benefit and who's driving more benefit from mop-up or adjuvant chemotherapy. Shown here are now the predictive power of ctDNA. In green are actually patients who were ctDNA positive at baseline. As you saw in the previous curves, if you didn't do anything about it, every single patient had recurrence. However, in the study, these patients got mop-up chemotherapy. Their recurrence rate or risk was almost the same. So you were able to improve and shift these curves up to folks who were negative at baseline and stayed negative, as opposed to the ones who were positive or changed positive. They were the ones who did worse. But clearly, as you can see, this was not a myth that everybody recurs. You can change the outcomes, whether it's stage 2, 3, and select stage 4 patients, with or without mop-up chemotherapy. You can clearly see that you can change their outcomes. And this is what we do and had been doing for years, but now we have proof of that. The field is not ready for de-escalation, but it's striking to note that patients who had ctDNA negative versus whether or not they got chemotherapy or didn't get chemotherapy, their recurrence rate was the same. Again, ctDNA is not to be used in isolation. However, with better assays, better technology, and more data, it is pretty striking to see how we can tease those folks apart. Yeah, at least in trials right now, there are escalation and de-escalation paradigms already being adopted, and this adds more data. This is in the ballpark of some of our GU colleagues. This is a study looking at immunotherapy in the mop-up setting for urothelial cancer. The actual study was negative, but when they looked at ctDNA positive versus ctDNA negative, the immunotherapy benefited more, not surprisingly, the ones who actually had leftover cancer in their body as opposed to who didn't. So, these drugs are expensive. If we could be more smart about who gets immunotherapy, this can lay the foundation for, being a predictive marker more than just a prognostic marker. Again, this is not just limited to one cancer type. At ASCO GI, we saw hints, again, with some of our research and some of the other collaborating colleagues looking at pancreas cancer, and you keep seeing these very marked differences between ctDNA positive and negative cohorts of patients. Upper GI cancers at ESMO with our colleagues at MGH. And the other huge advantage that, again, goes underappreciated is the fact that liquid biopsy turnaround and also completion is a major issue. This is a huge study done in Japan. What they did was they started screening everybody for tissue genetic testing, and then the so-called Godzilla study was looking at liquid biopsies, and they compared outcomes head to head. Even in a trial setting, in this case, 11% of the time, the tissue testing failed. In the real world, it's almost 20 to 30%. And more importantly, if you look at the turnaround time, again, this is a trial, well-controlled, proactive situation. It took on average 33 days to get the results back, as opposed to liquid biopsy being back to in 11 days. Nowadays, it's 7 to 9 days. Again, tissue testing in the trial setting is 33 days. In the real world is horrible. And again, no disrespect to my pathology colleagues, it is underestimated how often tissue fails, and more importantly, how timely can we get the results. This is not me complaining about the pathology department at any institution. This is a national and a global issue. This is a study that was just published early last year, which looked at turnaround of basic KRAS testing in the United States. 81% of the time, it took more than 15 days for the results to come back. I would be very curious to see what's the upper limit, because I can tell you sometimes that could be never, or could be months before we get the results back. The actual proportion of patients where we had the results back in a week or two, so we could act upon it, it's no better than a myth. And in the actual testing where they acted upon it, it even gets worse. So patients, for example, who have RAS-RAF wild type colon cancer, they benefit from anti-EGFR testing. We always question, why aren't we using enough anti-EGFR drug? Well, the basic reason for that is we never get the results back in time. And even when we do, it takes more than 2 weeks or so. So liquid biopsy can help with the turnaround. And also it's tumor specific. Some tumor types more notorious than others, where tissue testing is insufficient because sometimes ERCP or biopsies are not good enough. And again, this is not just GI cancers. In a so-called Nile study, they took patients with lung cancer where they did parallel testing on tissue, parallel testing on liquid. Liquid identified 87% aberrations, whereas tissue identified 67%. So almost, again, about identifying all the subsets, 20% more aberrations identified in liquid biopsy as opposed to tissue testing, let alone the turnaround time. This also helped accrue double the clinical trial accrual in Japan. And I feel as well myself, because of the utility of liquid biopsies, I've been able to practice precision medicine better, because it's also about, the first step is about identification. I may have a drug, but if I can't identify which patients to consider this drug in, well, it's a two-step process. First you identify the mutation or aberration that's actionable, and then you have to have downstream trials and options. A few years ago, we didn't have, too many trials or options or targeted therapies. So even if you found something fancy, well, what are you going to do about it? Because there was not many drugs or options. Nowadays, with clinical trials, agnostic approvals, actionable findings, you are increasing the pie in terms of the subset of patients who can benefit from these precision medicine-based therapies. And they pretty much work, in terms of the concordance issues. I think we're way beyond this at this point in time. So where is the future headed? We talked about the cancer having, the ctDNA having an impact at all phases of a journey of a patient with cancer. We talked about ctDNA in particular, but there's other kinds of liquid biopsies. And, this talk would already be outdated in a year from now, where there'll be so many other things that already are being published and making their way into clinic. CTCs are one of them, standing for circulating tumor cells. Again, this is from a patient of mine, where you can clearly see, shown here in these green circles, actual clusters of circulating tumor cells that you can tell apart from the blood testing by a collage of different panels, which merge together. You can clearly tell where are the blood cells, shown here in this pink, and where are the cancer cells. You can literally scoop one cell and consider single cell sequencing. So it's not something, like a future direction. It's already a present, something that we're already incorporating into trials. And for some cancers, like prostate cancer, breast cancer, these are things that are even available commercially and clinically. It also adds the advantage that you can actually do staining on it, like, for example, HER2 or PDL1 shown here in the panel on the left. Again, CTCs are also being captured through different mechanisms. One simple property that has been taken advantage of is cancer cells are heavier and they are less compressible. So just like straining your coffee or tea, some of the simple machines are using physics to just strain cancer cells, and then you can put them on a slide and again do testing, or even because you haven't put too much chemicals into the mix, if you do them in real time, there is the potential, and other folks have published on it. We haven't been able to accomplish it ourselves yet, but something that could be potentially done is be able to grow some of these cancer cell lines for potential organoids or cell line or drug testing. And some of the other liquid biopsies for CTCs are using antibody antigen approaches to identify CTCs and tell them apart from the other immune cells. These are, again, some of the different platforms and some of the research that we have done. And then, again, it's not the future. I was pleasantly surprised just, I think, a month or so ago, in the NCCN guidelines, at least for colorectal cancer, they now have listed blood-based next-generation sequencing, so liquid biopsy, so to speak, as an alternative to knowing the tumor's genetic status, whether it's the RAS or the BRAF or the HER2, as we talked about, as opposed to using that through tissue. For lung cancer, our colleagues in lung cancer were already doing that years ago. But again, as you can see, some of this concept is not relevant to just colon cancer, but other cancers as well. It goes without saying, you have to understand the limitation in the clinical context. For example, we do a lot of liquid biopsies immediate post-op. Background cell-free DNA noise can affect detection rate. So you have to be careful. If you had a negative finding, it could be a false negative finding. And the rate of sensitivity and the rate of detection of ctDNA can go up over time. So sometimes if you had, it's helpful and easy when it's positive, but if it's a negative signal, you have to think of it that you're thinking of finding a needle in a haystack. In the post-operative period, it's a bigger haystack. They say biology is king. It goes without saying that even within colon cancer, right-sided cancer, left-sided cancers have different shedding sites of metastases. For example, lung metastases are low shedding sites, liver are high shedding sites. So some of the trials are now using precision medicine-based therapies for liquid biopsies. It is integral components, using early stopping rules, using intensification or de-intensification of therapies, what to do after curative treatments, escalation or de-escalation paradigms. And the more important thing is liquid biopsies or some of these tests are allowing for novel therapies to be integrated. The next so-called holy grail, or the things that again are not the future, some of these specific or multi-tumor agnostic tests are already becoming available, is moving into the detection phase. So again, this is not the future. These are published results. One of the testing platform that's now commercially available, which is trying to detect almost 50 different types of cancer by just a simple blood draw. Not surprisingly, the sensitivity varies by different types of cancer and the stage at which you can detect the cancer. And every time I turn around, I hear about something new. I recently heard about something called fragmentomics. What that basically means is they can detect different kinds of sizes of cell-free DNA by looking at fragmentation patterns. even the patterns can tell us about the presence or absence of cancer, and even the type of cancer. So as you can see, I don't know what these signals mean, but you can clearly tell apart that there is something different about somebody who has a healthy signal versus somebody who has a cancer signal. And they're able to even predict patterns of recurrences when it comes to individuals with different types of cancer, making its way into the detection realm. With that, I'll stop here. And again, this is in a nutshell is something that's here to stay. In terms of options, it's having an impact at all phases of a journey of a patient with cancer.